Commonly due to systemic hypertension, but also from some cardiac abnormalities. So left ventricular wall thickens due to an increase in the workload, and the left ventricle loses elasticity and fails to pump blood effectively, leading to heart failure. Your EKG is going to have criteria. It's typically based on your QRS voltages. So we have a deep S wave in lead V1. Notice the common theme, such as V1. V1 seems to be consistent with all of these, and I'm realizing this now. Instead of just V6, now we have V5 and V6. So those two are at least like close together, right over here. Tallest. So we're looking for an R wave, QRS, right? A tall R wave of 35 millimeters. Is it even millimeters? Yeah, it is millimeters. And or an R wave in lead AVL, taller than 11 millimeters. That's really random. Just imagine a R wave in V5 and V6, super freaking tall. And R wave, we're looking for specifically taller than 11 millimeters for some reason in AVL. Diagnosis is made by electrocardiogram, not EKG. In this picture, we have a 12 lead for left ventricular hypertrophy. So where's our left ventricle, right? This side, right here. That's why it's V5 and V6. If the heart was in right atria, left atria, right ventricle, left ventricle, left ventricle is down here, V5 and V6. Showing left ventricular hypertrophy. So we're looking at AVL, here's AVL, and we're looking at V5 and V6. What do we have? This is super tall, right? So in V5, let's count them. We want 35 millimeters. So each of these is 5, right? 5, 15, what is this? Starting here, we'll just add that later. So 5, 10, 15, boom, boom, it's like 20. Still not 35 though. And we're looking for the R wave. So V6, are we like adding them together? It's hard to say. 1, 2, 3, 4, 5, 10, 15, 18, plus 2, it's like 20. So it's not 35. Is it saying together? Maybe we have to add them together, because that would make sense if that's the case, because now we're at 40 or 30, yeah, like 40. So the tallest R wave in V5, V6 taller than 35 millimeters. Doesn't say that. Well, we're not at 35 millimeters. So let's look at the R wave in VL. AVL. 11. We're not there either. So we have another terrible example. Unless I'm just reading this wrong. We're not looking at this. That's very pronounced. 35 millimeters. Well, this is millisecond. 0.12, 0.04. Oh, maybe we're multiplying this times 4, right? That's each square. So 5 times 0.04 is 20, times 2 is 40, so this is beyond 35 if we were going to put a number on it, because each square, I haven't done this in a week, which is crazy how much knowledge you lose in just a week's time. But each square is 0.04 milliseconds. I forget what the voltage is supposed to be on it, so I don't know, I have to go like way back into my slides, but anyway, point being, 11 on AVL, you're looking for 11 or more millimeters, and then V5 and V6, you're looking for over 35. And that's going to mean left ventricular hypertrophy, and I need to relearn where lead 1, 2, and 3 is, because I'm not even that confident on it right now. Same with AVF, AVL. I know AVF. AVF is straight down. AVL and AVR, let's see. That's left, AVL, AVR. So I remember that, but like lead 1, lead 2, I already forgot that. And I forgot how to lead an EKG strip, how to read an EKG strip. Review zones for ischemia, injury, and infarction. Early recognition is key to limiting the loss of heart tissue. Time is muscle. Be within that golden, we call it golden hour, or the golden amount of time. Yeah, golden hour. When the coronary artery is blocked, there are characteristics that change and appear on the EKG. So you have the ST segment depression. That's going to mean ischemia. This is in the early stages of a myocardial infarction. Once it turns into infarction, that's whenever there's more damage that happens and you see that ST elevation. So in the early ranges of detecting, we will see ischemia, which would be depression. Where did it go? ST segment elevation for myocardial injury, death of tissue, and then pathologic Q waves for infarction. ST segment depression greater than 0.5 millimeters or in 2 or more continuous leads in a patient with a chest pain or discomfort, unstable angina, or an N-STEMI, a non-ST elevation myocardial infarction. Greater than 0.5 millimeters or 2 in continuous leads. Suspect STEMI if for leads V2 and V3, the ST segment elevation is 2 millimeters or more in men older than 40. See, this is when it gets really specific and you just have to keep going through these rules. Lead V2 and V3 ST segment elevation is 2 millimeters more in men older than 40 years old, or 1.5 millimeters or more in women, if it is elevated 1 millimeter or more in other leads. Non-diagnosed EKG, absence of ST segment changes. This does not rule out the acute myocardial ischemia, injury, or infarction. Serial blood work and additional testing will be required, so we don't have all of those at our dispense to be able to determine, but we can get them to the doctor so they can determine that and monitor their troponin levels. And I forget what the other one, it's like creatinine 12 or something like that, is the hormones that your body, your heart secretes. That was on the test. Yeah, so what happens is whenever your heart's pumping more aggressively, it's spreading out. And because it's spreading out, it's like releasing these hormones because it's being stretched so much. And I believe, I can't remember if it's creatinine 12 or troponin. An early acquisition of 12-lead EKG in a patient who may have an acute coronary syndrome is essential. Obtain the first 12-lead within 10 minutes of patient contact. So it's the first thing you want to do, for the most part. Probably not. Obviously go through your ABCs for the test's sake, but your primary thinking of, okay, what's the first thing that's probably important? Let's get a 12-lead. This figure shows the evolutionary pattern of acute myocardial infarction. So here we go, normal state, right? This is what a pretty heart rate looks like. This is what mine looks like, yours looks like, unless you're dying right now. Ischemia or non-Q wave acute myocardial infarction. So you might not even have, it might not be detectable if you're having one right now, so you could still have this. This is our first state, ST depression. So our isoelectric line is here, QRS goes lower, right? It's hard to see on this, and then T wave repolarizes back to the isoelectric line, and it starts again and does the same thing, lower. Yeah, so it's gonna get, you can see the ischemia here as it looks normal, spreads out a little bit. Now we have elevation. We're starting to get injured right here. So what'll happen is it lowers, it goes normal, now it's starting to heighten. We're getting that elevation, ischemia. This is still just pain right now, angina. As it progresses and we turn into this, now it's getting injured because there is electrical activity that is no longer happening in this area. It's struggling to reload. until it gets like this. And then what happens? It dies completely, back to normal. Infarction. Treatment decisions are made of the basis of the patient's presentation and history, the 12-lead EKG findings, and any laboratory test results such as cardiac biomarkers. Correlate the patient's cardiovascular anatomy and the heart surface viewed by each EKG lead. So lead groups enable you to localize the EKGs in areas that show changes consistent with ischemia, injury, or infarction. This has been on the test, and I struggle with this. So if we're in lead one just by itself, I guess. Okay, here we go. AVL and lead one. We have high lateral wall, left ventricular. I don't know what CX means. Let's look at the ones that are, so I guess nothing in AVR. So you can toss AVR out, right? At least we've eliminated it to 11 options instead of 12. Yay. Or however many these are. This looks like, let's see, 1, 2, 3, 4, 5 different options. So there's 5 different options, 5 different angles that we look at the heart to determine where is it being destroyed from, where is the infarction happening. We'll start biggest first. Lead 2, lead 3, and AVF means inferior wall, left ventricular. Oh, what does that mean? Right coronary artery, yeah, RCA, right coronary artery. Ooh, I'm still smart. All right, so inferior wall, where's inferior? It's lower. Left ventricle, down here. So we know we're going low, we're left ventricle, we're right coronary artery. Okay, so it's left ventricle, but right side, right coronary artery. Yeah. So that's going to be lead 2, lead 1, lead 2, and lead AVF. Okay, so that's the biggest one that eliminate it. We're looking for 3 separates of these. We can cross this off, we can cross this off. We're left with each of these. So you just got to memorize these now. We'll start with this: high lateral wall, left ventricular coronary. So what is that X? LVCX. I know this is left artery, left anterior descending, high lateral wall. Circumflex, that's what that means, circumflex. Okay, because it's circumference of the heart, right? The coronary artery that goes around the heart, okay, we're good. I'm learning as I'm going. So lead 1 and AVL. Where's AVL? Left, AVL, lead 1, straight across. AVL, lead 1. Means that we're looking at the high lateral wall, left ventricle, because we're on the left side, left ventricle is down here. High lateral wall, right? Because we're going up here, the heart's down here. We're looking at it from the high point of view. So 1, high lateral wall, and it's on your lateral side. You got to pay attention to that. Like there's no other way to learn this unless you just break it down like a 2-year-old. Circumflex. So I guess that's the best way to view the wall if it's going all the way around, the coronary artery all the way around. We'll go to this one now, V1, V2. So where's V1? V1 is here, V2 is here. I feel like we'd still see circumflex here, maybe? Well, circumflex goes around the back. It's been a while, I need to watch one of the videos. Interventricular septum. So the septum is in the septal. Septal is down, no, inferior, septal's in the front. Intraventricular, so it's in the middle, right? V1 and V2, we're looking at the heart, even though the heart's kind of like off center, but we still have V1 and V2, gives us like a point of view that's towards the center of the heart. So if we're seeing it in both of those, then it's like it's almost like radar in a sense. Like you're kind of, okay, we have a detection here, we have a detection here. So if we split the difference, we know something is happening in the middle of those two. And I guess if one is bigger than the other, then maybe it's like a little bit closer to that one in particular than the other. So if you think of it like that, it kind of makes sense. Intraventricular septum, so left anterior descending. So you have your left, on the left side, anterior in the front, descending, it is going down. So yeah. What's left? Did we already do this one? Inferior wall? I can't even tell, like these colors look the same to me, so that I'm struggling right now. Are these all the same? No, these aren't. Okay. Anterior wall, left ventricular, left anterior descending. So V4 and V3. We crossed off V1, V2. Let's go to the next one, V3 and V4. Just pretend that I'm down here. So V3, no, V4. V4 is right here, mid clavicular line, right here, 4. And then V3 is right next to it. So that means that we're looking almost at where V1 and V2 was, but we're looking slightly to the left of it. We're looking at the anterior wall still. Intraventricular, yeah, anterior wall, just like left anterior descending in these two. So anterior wall, left ventricle, still in the left ventricle, left anterior descending again. So now we're looking at the outside wall instead of the inside, right? Instead of like the split in the middle of the heart, we're looking at the wall itself of the heart, the most anterior portion of the heart. Yes, left ventricular. And then what's left is the low lateral wall, left ventricular circumflex, V5 and V6. So here again, this is V5, V6. We're looking at that side, and we can see the circumflex completing around it, low lateral wall, left ventricular. That was a lot. Is there anything else? Perfect.